Thanks so much, Holly. Welcome back, everybody. Happy 2026. Welcome to our first Leaders in Public Health of the Year. I'm absolutely thrilled to see so many of you here for what is sure to be an absolutely incredible and inspiring conversation. I am absolutely overjoyed to have our first Leaders in Public Health of the Year be the one and only Dr. Marianne Etiebet. For those who are not familiar with her, Dr. Etiebet is the president and CEO of Vital Strategies, where she leads a team of over 400 individuals working in 80 plus countries across the globe to ensure that everyone everywhere is protected by equitable and effective public health systems. Today, more than 3.3 billion people worldwide are covered by public health policies that Vital Strategies helped achieve. Before being at Vital Strategies, Dr. Etiebet directed Merck for Mothers, which we'll talk a little bit about today. It was a $650 million global health initiative that expanded access to quality maternal health care for more than 50 million women across 70 countries, really living our YSPH vision of linking science and society. She was also Merck's Associate Vice President for Health Equity. Her career began in academia and public health, in infectious disease, including work with HIV/AIDS programs in Nigeria. And way back, she was a Yale College grad, a Yale School of Medicine grad, a Yale MBA grad, and took a lot of classes here as well.
I did, yes.
So we're quite proud to welcome Dr. Etiebet back to her alma mater to have this conversation about global health, about leadership, about all the things. So welcome, Marianne.
Thank you so much, Megan. I'm so excited to be back and see some friendly faces. Also really excited that I'm your first speaker for 2026. So let's get this going off.
Setting a tone in a good way. So I love to start with kind of a little bit. I gave the high level overview of all of your awesome titles and achievements, but we have a lot. How many folks in the room are students? If you could raise your hand just to give her. So a lot of really enthusiastic students who care about global health and leadership. So I love to start by kind of having our speakers share a little bit about their career journey, what got you to where you are today. So can you kind of share what were kind of some of those inflection points along your journey from undergrad through Vital Strategies?
Great. I think the short answer to what got me here today are people, People who believed in me, people who supported me, people who took a chance on me. So short answer. Long answer, you may know I was born and bred in Nigeria. And I still remember this image that I saw, being driven to school. I was probably 11 years old. I've shared it in other talks, so forgive me if you've heard it before. But there was a girl, probably 13 or 14, with a tray of fruit on her head, selling fruit at the side of the street. But what struck me was she had what we called in the vernacular bow leg, so she had rickets, a nutritional deficiency, but and I'm missing my trigonometry here, but the diameter, between her knees was actually longer than from her hips to her ankle. And when she walked, she had to swivel. And I was like, that has to be painful. That has to be painful. And she's still out there in the sun selling fruit. But she was also holding the hand of a young boy, 6 or 7, and he was wearing a school uniform. And I said, there is something inherently unfair about this picture. And, even at that age, that intersection of health, of education, of gender, and of economic opportunity, I think that's been the seed of my career. And that has really animated it or informed it, through all of those inflection points. I think, I identified health, as the foundation for all of the rest, and, started my journey to be a physician, came here to Yale College, actually, majored in political science. But this was in the 90s. And, this was the peak of the HIV/AIDS epidemic, both here and starting on the continent. And so, again, that's where I identified my ability to go back and make a difference. That's what I wanted to do. And recognize that to solve so many of these problems, you had to be working outside of the exam room. And so even though that, doctor-patient relationship was so important, in order to really support patients when they left your exam room, you needed to engage on a broader scale. And so, pursued the MBA, took lots of MPH classes. You mentioned my early academic career, but really was an excuse to go back to Nigeria and work on a PEPFAR-funded program. And many of you know PEPFAR, no longer exists. So again, thinking about what got me started. And while I was there, I caught what I call the implementation bug. Building things. Leaving something behind. And just made choices based on my ability not just to have impact on global health, but to have impact on the organizations that I was working in.
I love that as someone who also kind of has made my way through because of that desire for impact on but you had to start by being deep in the details before you could think about organizational
not just
impact.
Details. And I think that to be really effective, you have to have worked at the front lines. You have to have done some service delivery. I don't think that you can really understand, as you said, all of the minutiae that makes something work or doesn't work if you haven't had to experience it yourself.
I love that. And I think it's an interesting kind of lesson or thought for many of our students in the room as you're thinking about what your next steps are. And so many of us aspire to leadership, but thinking about how those first experiences on the front lines, whether it's in data collection and direct service delivery, shapes your journey. So, okay, so we've talked, tell me and give us just a little overview of Vital Strategies, again, for those who are not familiar with it.
So I call us, the best secret in global health.
No longer a secret. Now
I'm trying to change that, working to change that. But, we're an amazing organization. As Megan mentioned, a global public health organization that's focused on public health systems. And the reason I was so excited, for the opportunity to lead Vital Strategies was its approach, so not just data and science driven, but really focused on foundational health systems and strengthening foundational health systems by working directly with government and with the focus on data. I think the other thing that really excited me about Vital is we're actually focused on non-communicable diseases, and I'm going to start using jargon, which I'm trying not to.
It's okay.
But in global health, not too many organizations are, and we know that this is over 75% of the deaths are from NCDs. Most of that is happening in low and middle income countries, and so again, we need to be working on this, and Vital Strategies already was, and from a place of thinking about prevention, which again, not a lot of people do, thinking about policy change, which I believe is the lever for scale, for sustainability, and for equity. Policy change is hard. It takes time. You need to be in it for the long game, and so that also really excited me. An organization that was really committed to this. And then lastly, we have a climate health portfolio. And, I don't have to tell all of you, just how important it is to work at that intersection of climate and health. And we were already doing that. And so, just really lucky to join this amazing organization with such committed individuals working across low, middle, and high income countries and doing what I believed was the right thing in the right way.
That's awesome. And how, just so that Dr. Etiebet has an idea, how many of you in the room are from our Department of Chronic Disease Epidemiology? a good percentage. So really kind of focused. Yeah, Marcella, you can raise your hand too. Right, one of our, we have 2 departments of epidemiology, and yes. CDE is really kind of anything that's not infectious, yes. right? Yes. But those NCDs. So I love that. So okay, let's talk about the elephant in the room of global health. Right. So you're leading now this you've spent your career raised in Nigeria, came here, kind of have spent your career thinking about how we work as a global system. We're, in a moment of a little bit of chaos and destruction. You and I have both talked about this idea of earthquakes, or you've used the phrase of tectonic plates shifting. Can you share a little bit about how you're thinking about that and about what the future, how you're thinking about both how we make our way through this moment, but also defining the future?
Yeah, no, it's such an important question, and I think we need to think about now as an opportunity. When I also think about how I approach public health, we did do things that I don't think were the right ways to do things. Again, one of the reasons why I work in public health is growing up in Nigeria, I saw that so much of the work was not sustainable, didn't involve local economies or local communities. And so, thinking through how do we do that differently? Thus also my stint in private sector, thinking that private sector can be an engine, not just for innovation, but for sustainability and pulling in local economies. And, what could that look like if we did it right? And so, right now, I think we have to be really honest with ourselves about what didn't work and why it didn't work. One of the things I've been thinking a lot about is, why don't we have the public behind us? And we can't be successful. We're public health. We need to put the public back in public health. And why don't we have the public's trust? So we need to get back the trust of the public. And so thinking through, the other thing I like to say, we, as I said, we talk in a lot of jargon. And not many people even know what public health means. So, how
my parents until COVID would be like, Megan, what is this public health thing?
Exactly. And so, how do we talk about the work that we do in a way that relates to people's lived experiences? And some of what I say is, all we're trying to do actually is just make it easier for you to live your healthiest lives. So the situation is default health. You don't have to think about it. It doesn't have to be hard. That's what we're trying to do, but we're not communicating it in that way.
So how are you thinking, kind of from a really kind of concrete perspective, how are you thinking about some of that kind of partnership on the ground today within Vital Strategies? So we are in a time where, I know your organization has been funded by USAID, and right. So how are you thinking about not just not losing some of those relationships, but recreating them differently? Can you share a couple of examples?
I think that the most important relationships, and the other thing we need to do in public health is those relationships have to be bi-directional. We need to listen better. We need to co-create. We need to co-create with communities. And so during this era of disruption, we need to be doing everything we can to maintain continuity with communities. And using this as an opportunity to have real conversations about what's working and what's not. You asked, how is this playing out? I think one of the ways that it's playing out on the global health landscape is now creating the space for governments to actually articulate what their national priorities are and how how global health financing should be in service of their national priorities, not of the funders. Yeah, and anyone who's worked in global health will know that most of our global health architecture is based on vertical programming for a couple of diseases, and the way that it's being implemented is in silos, not linked to national systems, and when the funding stopped, we saw what happened. Things, ground to a halt. And when you think about the billions of dollars that we spent over the decades on these issues, and in many places nothing to show for it, that's on us. And so what we need to do now is really think about how do we work better with governments. I think accountability and transparency is key, thus coming back to the data. Coming back to the data. But I also think humility. We pride ourselves in the evidence, yeah? But we also have to recognize that we don't always know what the solutions are.
Amen.
We don't always know what the solutions are. And we need to create the space for homegrown solutions to be able to surface and for us to support and amplify them.
Yeah, and I love that de-siloing thing. Those within the school know as we've kind of created our new strategic plan and have thought about our areas of scholarly focus, we've been doing a lot of thought about kind of these ideas of intersecting epidemics, and that if you're focusing just on obesity or just on HIV, you're missing the bigger picture and how they work together. And I love how you all are kind of looking at that from a governmental relationships standpoint. I want to go a little deeper on the trust thing. We spend a lot of time here thinking about how we rebuild trust, and we're actually going to have a conference on February 10th to students and others in the room. Dr. Mike will be here. Sign up for our afternoon session if you haven't already. That is open. But I'd love to learn from you about how you think about trust and kind of first principles as we rebuild it. I like trying to be honest about how we got here, which is a big, I believe in kind of honesty and vulnerability. Yeah, you have a different perspective than I do, so I'd love to learn from you. Well, a different lived experience.
And I think, all of the different career experiences, have informed that. You talked about Merck from others. I think that was also very life-changing for me.
Yeah.
When I joined Merck from others, a lot of our focus was on global work. But as many of you know, the maternal health and mortality inequities in this country are outstanding. Yeah?
Outstandingly bad.
Outstandingly bad, astonishingly.
Yeah.
And, as we thought about it as a team, our orientation had really been, if we improve this, rising tide lifts all boats, but it doesn't. Yeah. And the analogy I use is, rising tide lifts all boats if you have a boat.
Yeah.
But if you have a raft, if you've got a canoe with holes in it, if you don't have a life preserver, it doesn't lift you. Yeah. And so how do we change that? I think also because we work with our group, with our tribe, I think we forget that not everybody, kind of understands the assumptions and the assumptions we work under, or the foundations we work on. And something as simple as saying we want to reduce disparities, people would understand that as, that means the folks who are, have good health outcomes, we now want to have the average come down. Yeah. That's not what we're saying. We're saying we actually want the folks who have, poorer outcomes for them to get better. But that was not always the initial understanding example. Or reaction of folks, and unless you realize that, you may not know where the pushback is coming from. And so long way to answer your question about trust. Yeah. our lesson there was we have to listen. We have to actually hear what people are saying. We have to respect them and respect what they're telling us and what we're hearing, and then we have to respond to it. And this also I felt was, one of the fundamental factors driving maternal mortality. People were not listening to Black women. I have pain. Something doesn't feel right. Fundamental, yeah. You listen to all of the stories of maternal deaths in Black women, and there is a point where somebody did not listen to them, did not take what they were doing seriously, and did not respond adequately.
How do you think about setting up systems that are able to listen and respond to those gender, racial, geographic, economic differences? If I don't use the word disparities,
So really interesting. I've been thinking about what's the challenge, what's the opportunity of the future. So have to talk about artificial intelligence, and there's an opportunity to use that to listen. Where are people talking now? They're not. My daughters are not talking in real life.
My kids neither. I keep trying.
We're talking, but this is this is not how people talk anymore. They're talking on social platforms. So how do we actually listen on social platforms and figure out what people are saying there? Artificial intelligence can be a tool for that, and some of our teams are using that to understand what's going on on these platforms. And so I think it's, as we think about public health and data, it's not just understanding where pathogens are going. It's understanding where talk's going. And I think that has to be one of the data points that we elevate. Communications has to be just as important as how we think about pathogens, because right now what is influencing health is misinformation and disinformation, and we need to take that seriously.
And that is tremendous, and I'm so excited to learn what you guys are doing about kind of AI and social listening. I think that's just outstanding to elevate voices, right? In some ways, it's a great way to identify and elevate voices that are not traditionally part of the conversation. If I want to go a little further kind of on the maternal health, because we actually haven't had a lot of leaders in public health who talk about maternal and child health, despite the fact that I know it's an issue that many of our faculty as well as students care about. How have you thought about kind of maternal health as a vital sign, like setting up systems, again, like knowing where your leadership is so extraordinary, how do you think about setting up systems that pay attention to it?
So, great question, and I love that you use the term vital sign, because again, our disparities, maternal mortality is reflection, vital signs of our society, not just of the health system, but of society.
That's interesting.
It's the intersection of gender and racial inequity that we are seeing, like in our health systems. And so, as you think about systems, one of the things we thought about is, the deaths are actually not happening in the hospital. They're happening in the community. And so your system has to link to the community. And how do you do that in a way that's institutionalized? So that's, one way to think about, building systems that link clinic and community. I think, another thing that, we thought about from a systems approach, and this is back to the policy comment I made later, we did a lot of work on quality improvement, but how do you actually incentivize that work? How do you make it stick? And I think policy has to be part of the equation.
And did you were there particular policies or incentive structures that you found worked better to either get measurement or to make sure that things that actually worked were continued?
One of the things, and I would get pictures of people sending me this. Again, back to the primacy, I think, of really talking with people, with patients, with individuals, with pregnant people and their families, is that has to be the focus, that has to be the center. And so one of the things we did was making sure people had the information on what the warning signs and danger signs of maternal mortality were. Because again, assumption, we assume people knew what those signs were. And so it was something as easy as making sure that was embedded in discharge planning. And, we worked with the Association of National Nurses, putting it on fridge, magnetic cards, not just leaflets, you're coming back from the hospital, it's, put it on the fridge. And making sure that, that now became a requirement, for all hospitals to have this type of discharge planning and this type of discharge information. When I left Merck for Mothers, I think 12 states, had now made that policy. So as I said, I would get pictures of, people who've been on my team and, look, here's the magnetic card, we were given. And it was just so exciting to see that. Again, back to this point about changing everyday experiences and everyday lives of everyday people, that's what you want to see.
I love that. And it's such a cool example of how, I think so often we think about public health as being something that sits purely within the government, and that's of course part of it, but that private sector, your nonprofit sector, kind of all of the ways in which those play together, and the community element. How those all play together. Excuse me. All right, I'm going to take a step back because another one. One of my great pleasures about bringing in leaders of public health is talking a little bit about leadership. And you and I have spent some time together, and we have this conversation about how do we sustain ourselves as leaders. And I have two questions around leadership for you. One is to talk a little bit about kind of what your North Star is. How you, right, and you shared the story at the beginning, which I imagine is part of that. Yeah. But how do you keep yourself focused on the big picture, on that? What is your North Star, and how do you hold that for yourself?
Yeah, no, it's I think part of it is I come back to humility. Yeah, it's not about being right, but it's about doing right and doing right by. Yeah, and so the North Star is, am I making a difference? Am I, did my journey through this place, leave something behind? And if the answer to that is no, what exactly was I doing? So that really is my North Star. Is my work making a difference to people's lives? And I think that there are many routes that you can take, to get there. I think also, it's about obviously not doing harm during that process, but how am I also elevating
others?
How am I also creating opportunities, for others? I think one of my leadership lessons was, getting comfortable with using my power. Yeah.
Love to learn about that.
Yeah. No, and it was a thing, because sometimes we're uncomfortable with using our power, but when you use your power to open doors and create opportunities for people, and you see that come back in so many different ways, you actually realize, the giving out power, the dividend of that is something that is as renewable, and just grows and grows. And so I think that was, one leadership lesson. I think, another one, and I'm blanking now because I'm perimenopausing, but let me.
I'm with you.
It will come back. But another one that I share with the team is that flow state of leadership. Yeah. So the flow state of leadership is when you really understand where your team wants to grow, how they want to grow and learn and develop skills. When you can match that with the value your organization can build or grow and create, and match that with the need outside in the world, like that's a flow state. Yeah,
so that's gorgeous when that happens.
And so, that's what I'm looking for, as I think about the options and decisions, of leadership.
I love that. And I'll say, as you share that kind of around the power thing, there's so many mythological figures of kind of as women, right? Like of queens or for those who have Elsa, right? Like if you think about Frozen and kind of young Elsa with her gloves on versus old, like I just get that vision. Let it snow. But
let it snow.
As you talk about the power thing, that's gorgeous. So, all right, another leadership question is around the political moment. So you work with governments, and gosh, geopolitics are a little complicated right now, but you're an organizational leader, and what you do has implications not just for you, not just for the topics you're working on, but for your 400 plus people that work with you. So how are you navigating that?
No, so
I'm asking really easy questions.
So even before that, coming back to global health, and public health, we're all taught, that the 80% of the determinants of health are actually outside of the health sector. But I think what the last year or two has shown us is that the solutions are also 80% out of the health sector. And so if we stay in our silo, we're not really going to make a difference. This is not just the public-private, nonprofit, kind of silos and sectors, but the health, the transport, the education. And I think now the raw power of geopolitics, and
indeed,
and for global health, what you are seeing now is that the negotiations are not just happening within health. Ministers of health, presidents, ministers of finance, that are determining what the health budgets are, they are negotiating where health, I was thinking about this poker game, like health is just one of the cards, There's tariffs and trade. There's security and war, and there's industry. There's data, selling your data,
and energy,
raw minerals. All of this are now part of the conversation in a way that they weren't, 2 years ago. And so when you think about, how important is health in that deck. Not really. And so one of the things we need to figure out is, again, back to this putting the public in public health. Unless the public are clamoring for this, you won't get that political will. And public health will lose out, in that game of cards. Is that the
Okay. So Game of Thrones, Game of Cards. I think that's it's interesting. So Harvey Feinberg, who is a mentor, who was he was dean of Harvard School of Public Health, provost at Harvard, president of IOM. He then went and worked at the Carnegie Endowment for International Peace, and a large part of his work was thinking about how to have global health security as a driver of, and that's what I'm hearing you say too, is like both how do we have health be a metric within, energy or data, but also how do you make sure that the political power is not going to come from money necessarily within the health sector, but rather from public experiences of and desires for health.
And I think people recognizing that health is an economic driver. And really understanding that. And at the end of the day, health is people. And so this is about protecting your future generation. But we need to be able to talk more, on that level. I think so many people are still thinking about health as a cost. It's just seen as a cost. It's not seen as an investment.
Right. Like if we're talking about their political leaders who are talking about fertility, right, or the demographic cliff, and understanding how health serves as a driver of that. Oh, so if you talk about the future and the number of students in the room, it can be a little dispiriting to hear us say that health is not so important, or to kind of look at global politics. But
not that it's not important, but it's again, back to this, we need to do our jobs differently so people understand just how important it is to them, them being successful, and again, making sure that incentive structure aligns.
So what do you hope to see from our future generations of leaders? Like, what skill sets or what things would you want them to spend time working on?
So, the unknown unknowns. Yeah. I think that honestly is it. I think we don't know what we don't know. And part of scholarship and learning is being open to that black box, that we don't know what's in there, and discovery, of that. I think from looking to the future perspective, I think we have to get out of the way. I think we need to figure out. How
did we get to be the generation where we have to get out of the way? I'm with you.
We have to get out of the way. I think we don't recognize how stuck we are in how we do things. And I'll just give an example. Part of the work Vital Strategies does is around communication campaigns, to support policy change. And, one of the things really pushing the team to do is, again, this co-creation. We're trying to, who are we trying to engage? And if it's young people, we are not the ones who should be developing those campaigns. But it's hard to give up control, because if you say, okay, you 22-year-old, help us develop a campaign, on tobacco control. Like, oh my gosh, what are they going to come up with? and they came up with stuff that we would not have come up with, and made us feel a little bit uncomfortable, and maybe wasn't 100% accurate, maybe wasn't 100% kind of politically correct, maybe used words that we wouldn't have used, but it got through.
It did.
Yeah.
That's awesome.
So I think that's the losing control piece, and being comfortable with losing control. And so, I think, as I said, we have to kind of get out of the way a little bit. But, at the end of the day, it's, why are you here? Why did you apply? Yeah. It's remembering that. Yeah. And it's surrounding yourself with people who share the same purpose. And co-conspiring with them, to make it, figure out how to make it work, and I always say I used to say you need 2 people, but you actually kind of need 3. Yeah. So if you have 3 people, that you can co-conspire with, and you can start something, and once you start something, I always say, build it and they will come. Yeah, they may not be ready for you yet, but if you build it, they will come. And I think similarly, if you start building it, maybe we will catch up with you to you as you do that.
I love that. I absolutely love that. And as we have students taking photos, and it makes me so happy. Thank you. I'm going to open it up to all of you. We've got about 10, 15 minutes. I want to hear your questions for Dr. Etiebet. Yes. We've got a microphone. And if you don't mind introducing yourself, because I know you, but she doesn't. So, yeah.
Hi, my name is Swandima. I'm currently in the AP MPH at YSPH. Thank you for the talk. My question is that, when you spoke about observations in global health and lessons to be learned, I'm wondering what you thought very specifically about how a lot of the work in global health gets done in the global majority, and a lot of the funding originates in the global north. And, the dynamics are a bit distorted, both in terms of outcomes and various other things. Any observations about how that dynamic can structurally be changed or improved for better outcomes and for more empowerment of grassroots communities in the global? Thank you.
So, we talked about using your power.
Yeah.
So I used to lead a foundation. And or an organization initiative that act like a foundation. We gave out money, we gave out grants. And, so one of the things, we thought about, and this was, this was 2020, I guess, 2021, was, how can we change, how global health is implemented? What can we do? And, we actually had a lot of power, but were we exercising it? And so what we did, and I used to say this is our epic journey.
Mm-hmm.
How can we make sure that how we think about resources and resourcing is equitable? How do we think about, that's the E, equitable. P is proximate. The decision making, the leadership is most proximate to the work. I, is inclusive. So all of the work. Again, we're bringing everybody we need to bring into to decision making and how we're doing the work and how we're measuring the work. That was another thing. Yeah, like we're so
we got plans around measurement.
We're so focused on metrics, but who's deciding what metrics matter? Yeah, who's deciding which are the metrics that matter? And then C is the collaboration. And so we actually developed our kind of assessment schema, for giving out grants to reflect this. And even a simple thing of asking the question of who's on your board and what's your leadership structure. We also asked the question on, for the letter of intent or, the first, the first submission. Did you co-design the solution with communities? And, we got, emails saying, we didn't quite have time to co-design with communities, but we promise we will in the grant, yeah? Or, we're changing our board, it's, so that changed behavior, yeah? People changed their boards because of that. People changed how they developed proposals, because of that. And so, to your question, yes, global health, there are real power dynamics in global health, and I think unless you not just recognize them, but you walk through space, acknowledging them. When people say, "Oh yeah, the work you do is amazing, thank you," yeah, you have to recognize that they're saying that because you're giving them money. So of course, what you do is great. Yeah, of course what you do is great. So you need to figure out how what you do is actually not great and figure out how to get that information. Yeah, and so I think, from a global health architecture perspective, I think the easiest way to get there is to make sure, as you said, people from the global majority are in these seats that are making decisions and allocating budgets.
And it's Indian health and Nigerian health and Brazilian, right? Like the global health term, it's like what, everything but the U.S.? Yeah. Like what does that mean even? Exactly. Right? Yeah. Stephen and then Nikki, and then maybe we'll do a Zoom question if we have time.
Thanks very much for visiting us.
And do you want introducing yourself to Dr.
Yeah, I'm in the School of Medicine here and also in the Department of Epidemiology of Microbial Diseases at Public Health. And for those of us who have always worked in partnership with NIH on global health issues, it's been a little bit of a rough ride the last year. And you've had criticisms, you mentioned, of the way we used to do global health. I'm really curious if you have a suggestion or two. What would be a better way for our investigators and NIH, if we could, to re-envision how do we do global health going forward?
Yeah, no, great question. And I think from a research perspective, again, simple things. Who's first author? Yeah. I had the opportunity while I was here at Yale School of Medicine. I think it was the Curtis, fellowship, to go to South Africa. and do research, thinking about, how do you give credit, to all of the people you worked with, during that time.